Good morning, I'm Dr. Lance. I represent the other half of the USAFA contingent here at the conference. Just a quick note, on your evaluation form, my name is not on the evaluation form. So if you like what I have to say today, feel free to write my name on there. If you don't like what I have to say, well, forget I ever told you it's not on there. Okay, so I have no disclosures. All right, so the objectives of my talk today is to discuss some common applications for sonography in the thigh and the knee, to develop an approach to evaluate the thigh and the knee with ultrasound, and we'll discuss some sonographic anatomy and some common pathology. So some common applications of ultrasound in this area are to evaluate muscle injury, to give a cyst versus solid mass evaluation, dynamic evaluations, specifically the extensor tendon and the extensor mechanism. We can look at neurovascular structures. Of course, we have image-guided procedures, which Dr. Campbell is going to discuss in a minute, and then internal derangement of the knee. I mean, typically we don't get requests to evaluate internal, derangement of the knee with ultrasound. But sometimes you get deployed, and you can look like a rock star if you go out there and diagnose a meniscal tear or posterolateral corner injury with ultrasound. So we're going to start with some thigh anatomy. We know that the thigh is a rather large anatomic structure, and sometimes when you evaluate the thigh with this relatively small probe on this thigh, it's easy to get lost. Typically at our place, we get a request to evaluate a thigh lesion. The tech goes in there and drops a probe on, here's the lesion, and marks something in a muscle, around a muscle, and you stroll into my office and say, here, Dr. Lance, you look at this, and I see this lesion in the muscle. And I'm like, well, what muscle is that? I'm like, I don't know. So we go back into the room and we put the probe on there, and I'm looking at the patient. The patient's got 6 inches of insulation around their thigh, and you're like, oh my gosh, I don't know where I'm at. I'm totally lost in this big patient. And I think, big things are actually good. We're here in Texas, and Texans like big things, and I'm from, where I live in Colorado, we like big things. In fact, I got a comp day coming up, and I'm going to go big at the resort. And here's, Dr. Pinero and I, going, getting our big air on. And I get thinking, about these guys who go, flipping around in these terrain parks, doing all these crazy tricks, the Shaun White types. And I think, how are they able to pull this off? And I realize that they have one of 2 things, actually 3 things, one of them being gonadal fortitude, but the other 2 being is that when they take off, they have a plan, and when they're in the air, they have a point of reference, so they can actually pull these tricks off and land them. And so, too, when we do our ultrasounds, we need to have a plan and a point of reference. Otherwise, we're totally going to eat it. And we'll have the sonographic yard sale, with much like this guy. So he's up, he's going. Oh, yard sale. Oh. I think I counted 8 flips there. Okay. So we don't have the yard sale when we evaluate. So when we evaluate the thigh, of course, we have the 3 anatomic compartments, the anterior, medial, and adductor compartment, and their respective anatomic structures. And when we approach the thigh, we want to orient ourselves to an easily identifiable structure, like a bony landmark, an origin or insertion, vessel, or a septum. So let's go over some anatomy pictures here. Just a note, in your syllabus, I took a lot of the pictures out, at least for the talk. They're in your syllabus, and you can peruse them at your own, your own time. But I've kind of attenuated here because of the time restraints. Just a note on this picture, though, is just to remind you of the normal sonographic appearance of muscle, which is hypoechoic with these interspersed echogenic septa. So that's normal. So typically, when I evaluate the thigh, I like to start with the patellar tendon, at least at the anterior thigh. I start with the patellar tendon, and that's something, the quadriceps tendon, I'm sorry. And I can find with patella, and then I notice that the quadriceps tendon has its normal hypoechoic appearance with, sometimes you can actually see the trilaminate appearance that you can see here on the MRI. And I can follow the probe proximally in the transverse plane until you can see the rectus femoris muscle, which is this ovoid hypoechoic structure. And then from there, it's easy to identify your vastus lateralis, vastus medialis, and vastus intermedius. If the lesion is lateral, I can swing the probe laterally and follow out the vastus lateralis until I hit this intermuscular septum, and then I know I'm right adjacent to the short and long head of the biceps femoris tendon. If the lesion is medial, then I can swing the probe medially from the rectus femoris, and I can look for the neurovascular bundle, the intermuscular septum, saphenous vein, something to orient myself. And then, of course, posteriorly, you have the neurovascular bundle, the posterior intermuscular septum, and then the sciatic nerve. So let's talk about some basic thigh pathology. Here's a patient with anterior thigh pain, and you have the left and the right for comparison. You have this ill-defined echogenic structure. You kind of lose the internal architecture of the muscle, and this is the appearance of a common rectus femoris contusion. Contrast that with this image of the vastus lateralis, the vastus medialis, and you have this hypoechoic defect within the muscle. And if you did dynamic imaging, you actually see the muscle separate. And this is the appearance of a muscle tear in the vastus medialis. So what's the difference between a muscle contusion and a tear? Well, contusions initially are hyperechoic. You can get some hemorrhage in there, and they can evolve to become hypoechoic with time. And you typically lose the internal architecture of the muscle, versus a tear is a defect, which we can use dynamic imaging to really see the extent of the defect, if it's a partial versus a complete tear, so on. And then often, if these muscles, with over time, can actually become hyperechoic, can calcify as they heal, as we see in this case of the anterior thigh, and you see all these linear echogenic shadowing structures in this case of Myositis Ossificans. Well, here's a case of a palpable thigh mass, and we see this hyperechoic structure delineated by the calipers. But you notice that the internal architecture of the muscle is maintained, unlike on the other case. And when Doppler color is applied, you see that the increased vascularity, of course, the waveforms. And this is a vastus lateralis hemangioma. So it's important to remember to always put color on your imaging. This is a case that, not in your syllabus, was just sent to me last week from one of our radiologists in Qatar, Dr. Blazard. And this was a individual who had a mass in their leg, and so he was able to see it sonographically, and then he went downtown and the town there, and they got an MRI, and there's an enhancing lesion in the VMO. So here's a patient he was an IED victim. He has a thigh mass, and you see his hypoechoic mass, and then you put color on, and you see this peripheral flow, and it's adjacent to the superficial femoral vessels. And of course, it's got these arterial waveforms. It's a typical appearance of the SFA pseudoaneurysm. So again, in all these cases, you want to make sure you use color. I think that's been talked about extensively in this course. Just to remind you again, use the color. And if there's any questions of the solid component, you got to go to an MRI. All right. So moving to the knee, of course, rarely you're going to evaluate the entire knee with ultrasound. But I like to divide the knee into four areas: the anterior, or the extensor mechanism, the medial and lateral compartments with their collateral ligamentous complexes, and laterally, of course, you could also look for the common perineal nerve adjacent to the fibular head, and then the posterior or the popliteal fossa, and then, of course, the omnipresent Baker cyst evaluation. So our extensor mechanism, here's a panoramic view of the extensor mechanism, and of course you have the hypoechoic quadriceps and patellar tendons. Now, focusing on the quadriceps tendon, this is best evaluated in the sagittal plane, and in this image you can see the trilaminate appearance of the quadriceps tendon as it inserts on the patella. And deep to that, you have the leaves of the suprapatellar fat pad, and of course the fluid in the suprapatellar bursa. And you have to excuse me, I turned some of these images 90 degrees just because it looks prettier. And then here's a MRI correlate. Now, if you turn transverse on the quadriceps tendon, you can see again the hypoechoic quadriceps tendon, and then the fat deep to that in the suprapatellar fat pad. And then often you can get a nice view of the hypoechoic normal cartilage in the trochlear groove. So the patellar tendon again has a uniform hypoechoic fibular appearance, and you can see Hoffa's fat pad deep to that. It's always good to just peek at Hoffa's fat pad, make sure there's no lesions in there. And just a word about the extensor tendon at the patella. One thing that we can see relatively well sonographically is that the quadriceps tendon, as it crosses over the surface of the patellar tendon, actually has fibers that continue over the entire course of the tendon and into the patellar tendon. And some people think that the patella is actually one big sesamoid bone, right? And so you can see those hypoechoic fibers here on the surface of the patella. and it's demonstrated here with this MRI that those fibers are continuous. Distally, the patellar tendon inserts on the tibial tuberosity, and you can often see fluid in the infrapatellar bursa, which can become inflamed and can be a cause of pain. You swing medially and laterally, you can see the hyperechoic patellar retinaculum and the MPFL. All right, so some extensor mechanism pathology. Here's a case that we had at the academy several months ago, and it was referred by orthopedic surgeons. The guy had a total knee replacement, and they said, well, he's having trouble extending his knee. Can you guys take a look? So, all right, so the sonographer went and took these images, and they saw this abnormal-looking quadriceps tendon underneath his insulation, and he saw that the quadriceps tendon made it to the patella. It didn't look quite right, though. It's like, well, yeah, I think it's intact. I'm not sure, but no dynamic imaging was done. Okay, so we got radiographs, and there's this large avulsion fragment coming from his patella here. So we know he had blown it out, and it was osseous avulsion of the quadriceps tendon. So MRI was performed, and we actually see how the quadriceps tendon was tucked behind the patella in this case, and that may have led to some of the confusion. But the confusion would have been alleviated if dynamic imaging was done. So how do we do dynamic imaging of the extensor mechanism? Well, there's 3 ways that we can do it. Obviously, you have the patient try to flex the knee. If he doesn't want to do that, you can squeeze the thigh, and if not, you just yank on the patella and see if you can see any movement there. Of course, you want to look for the hypoechoic defect or hemorrhage to fill the defect, and then look for any avulsion fragments. Here's a patient with infrapatellar pain, and within the fluid-filled bursa, there's this echogenic material which is hypervascular, and is a typical appearance of infrapatellar bursitis with synovitis. So that brings us to intra-articular masses within the knee. Now, this is a differential we know as radiologists, and sonographically, it's hard to be very specific to get to one diagnosis, but we can use findings that will help narrow the diagnosis sonographically. Things like calcified loose bodies, cortical erosions that you'd see in septic arthritis, so on and so forth. And here's a case which I don't want to steal from Dr. Campbell, so I'm going to skip it because he's using his talk, I think. So going to the medial evaluation of the knee, it's when we look in the cadaver lab today, look, you'll be surprised really what you can see here. And you can see the triangular body of the meniscus. You can see the deep MCL fibers of the meniscofemoral and meniscotibial ligament, and of course the superficial fibers of the MCL. And of course, when you're in medial areas, we've got to remember that the Pes Anserinus is there, and you can see the 3 tendons of the Pes Anserinus. And you can follow them distally as they insert on the anteromedial tibia, kind of the tendons become confluent. And this is important to look at because Pes Anserinus bursitis, you can see a fluid collection deep to this, which would be a cause of pain. Laterally, of course, we have the lateral collateral ligamentous complex, starting anteriorly with the IT band as it inserts on the Gertie tubercle. Here you see that tendon coming down, then here you get a shot of the lateral meniscus. Then as we move more posteriorly, we see the biceps femoris muscle and tendon and the fibular collateral ligament as they insert on the fibular head. And it's helpful to use the fibular head kind of as a pivot point. You actually put your probe, the inferior portion on the fibular head, and swing back and forth, and you can see both of those structures. And don't forget about the popliteus tendon as it swings around and inserts on its sulcus on the femur. So some collateral ligamentous complex pathology. There's a 44-year-old. He's actually one of our soccer coaches at USAFA, and he got taken out by one of his players in practice. And you see that the superficial fibers of the medial collateral ligament are thick and heterogeneous as they insert on the femur. And this is a grade 2 medial collateral ligamentous sprain. And we see here in this MRI correlate. Here's a patient. This is provided by Dr. Fajardo. Patient with lateral knee pain. And kind of in the anterolateral joint line, you have this hypoechoic structure, which is demarcated by calibers. And then deep to that, the normal echogenic meniscus is abnormal. It looks like it has a defect in it. And this is a lateral meniscus tear with a perimeniscal cyst. And again, you're probably not going to be asked to look for meniscal tears, but sometimes they have knee pain, and you're taking a peek and you may see these things, what it looked like on the MRI. I moved the popliteal fossa. Again, we have the tibial nerve and the popliteal artery. One thing that's helpful to look for posteriorly is the plantaris muscle, and something that we can actually see sonographically. deep to the lateral head of the gastrocnemius. And sciatic. So this is something I'm sure we've seen often. Please evaluate Baker's cyst. All right. So you go and you look at it in typical appearance of anechoic cystic structure, posterior through transmission in the right location, and no flow, Baker's cyst. Here you go, evaluate popliteal fossa mass, and here this is much more complicated looking, multiple septa, heterogeneous echogenicity. Put color on it, no flow, still looked ugly enough. It went to MRI and you see this, it just turns out to be a complicated Baker's cyst, all these fluid levels, post-contrast imaging, no enhancement. Then we have this case where evaluate popliteal fossa cyst, and you look at this and you're like, man, that is ugly. Septations, all this debris in it. Does it have a soft tissue rim? And the radiologist there, I'm sure in consultation with their orthopedic oncologist, decided to biopsy the mass. And this wasn't a cyst, but rather a fibromyxoid sarcoma. So again, it's important, even if the cysts look complicated, you want to make sure that you're confident that they are a cyst and they have no solid component, so you don't miss a deadly sarcoma. There's a case out of AGR several years ago with a patient with posterior medial knee pain, and it has this fluid structure deep to the medial head of the gastrocnemius, and this is what you'd see in a case of Plantaris Rupture. So it's just another thing to think about when you're back there. Here's a case that we had, evaluate popliteal fossa cyst, and then this time we see this echogenic structure, which is a phlebolith, and it has flow within it. And this is a intramuscular hemangioma, the medial head of the gastroc, which we see here on the MRI. So again, use your color. Just a brief to talk about superficial lesions for a second here. Often thigh, leg is a good place to get evaluation of superficial lesions from clinicians, family practice, so on. So again, use all the tools we have. Review the clinical history, look at the skin, palpate it. If there's specific locations that may key you off to a lesion, something like in area of the fibular head where you get a perineal or nerve lesion neuroma, something like that. Other available imaging. Typical things that we see, of course, varices, fluid collections, abscesses, nerves, lipomas, sometimes dermatologic lesions. So here's a patient with an anterior thigh mass. It's a typical hypoechoic serpentine appearance of varicosity, pretty straightforward. Compare that with this. The sonographer saw this. Oh, that kind of looks like a vessel. I better put flow on it. Oh, well, flow's not really in it, and it's kind of a hard mass. So I'll go get an MRI, and they got an MRI, and this was a thrombosis within a superficial vessel. So again, just a quick review of cyst versus solid mass. We all know the sonographic characteristics of a cyst. Typically anechoic, hypoechoic, posterior through transmission, mobile debris, no vascularity, versus a solid mass. And as was discussed yesterday, again, some tumors and some lesions may have posterior through transmission. So just because it has posterior through transmission is hypoechoic doesn't necessarily mean that it's a cyst, right? We need to put some color on, make sure that there's no vascularity within it. And of course, central necrosis can sometimes mimic an abscess or hematoma. And if there's any question of solid or progressive lesions, you got to get an MRI. So the flocculent thigh mass, skin's red and indurated, subcutaneous abscess. Again, palpable thigh mass, hypoechoic, kind of isoechoic with the surrounding fat, mobile, soft, little or no internal vascularity, and this is the typical appearance of a popliteal fossa lipoma. Compare that with this study. Here's again an ovoid mass, hypoechoic, kind of slightly hypoechoic to the surrounding thiam. Kind of looks like a lipoma. And then the tech puts the color on, and it's got flow. It lights up like gangbusters, and an MRI is obtained, and it's rapidly enhancing. And this turns out to be a peripheral nerve sheath tumor. So again, we use our color judiciously. So again, in conclusion, we discussed some common applications of ultrasound. Remember, always have a systematic, organized approach on how you approach the thigh, so you know where you are, and so you can accurately describe the anatomy. And we talked about some pathologic lesions. Thanks for your attention.